Welcome to Behind the Scope, Empire Urology Clinical Case Conversations. I'm Dr. Alex Small, Assistant Professor of Urology at Monefiore Medical Center, and I'm joined by my colleagues, Dr. Christopher Anderson and Dr. Gina Badalato, both Associate Professors of Urology at New York Presbyterian Columbia. This podcast, sponsored by the New York section of the AUA, aims to take you through the key clinical decision-making and technical aspects of high-yield urologic cases. We'll present hypothetical cases that highlight experts' differential diagnoses, preparation strategies, treatment recommendations, and thought processes. Each episode will guide you through the step-by-step evaluation and management of specific urological conditions, emphasizing relevant clinical guidelines and featuring a variety of guest experts. So join us as we explore the complexities of urological care and deepen our understanding of clinical practice together.
So welcome back, everybody. Today we are so lucky to have Dr. Nitya Abraham as our guest, our expert guest. She's a professor of urology at Monefiore Medical Center, has a lot of expertise in IRPs, was the former fellowship director of this program at Monefiore and the former program director. And we're really excited to have her with us. Welcome, Nitya.
Thanks for having me.
And so we're going to just dive right into an index case. We're really excited to pick your brain about a relatively common scenario. So we have a 68-year-old, otherwise healthy woman who presents to your office with urinary frequency and urgency and some urge incontinence. She wears about 4 to 5 liners a day, which are damp. She denies any stress incontinence. She's not overweight. She has no prolapse and any other abdominal or pelvic surgery. So this is a relatively common case presentation. Some of us may encounter in female pelvic medicine clinic or general urology clinic. What questions do you use to help characterize her problem, to kind of narrow down what her primary symptoms are? Do you use questionnaires in clinic? Tell us about your approach.
This is such a common case that I see in my own clinic. And so there are a series of questions that are really important in helping narrowing things down and just understanding the severity of what your patient is experiencing. So first, I just start with clarifying whether it's stress versus urgency incontinence. So is this leakage due to coughing or straining, or is it urgency and the patient is afraid of having an accident before reaching the bathroom? Is it a frequency issue? Or is the patient dealing with a lot of leakage? And I tried to assess the severity by asking about the duration of symptoms. Has this been something that's been going on for a long time? Or did it just occur in the last month? Because then I'm thinking about, could it be a urinary tract infection or some kind of neurologic issue that's presenting with urinary symptoms? I ask about daytime frequency, nighttime frequency, number of leakage episodes per day, number of pads. It would be great to do a bladder diary and really get much more exact information, but it's quite a challenge to get patients to fill out bladder diaries. I'm sure you've experienced the same. I get into their dietary history. So are they drinking coffee and how many cups a day? Are they going to Starbucks and getting a double latte? Talk about soda intake. And I also get into smoking history. And if so, how many cigarettes are they smoking in a day? And so that's where I start. But then I'll ask additional questions like, are they having irritative symptoms like burning with urination or blood in the urine, to rule out other diagnoses? And are they having any problems emptying their bladder, like weak stream or straining or feeling like they can't empty their bladder all the way? And many patients have had prior treatment. So I ask about prior medications, any other therapies they've tried, or even surgeries. And they may come up with, oh yeah, my PCP prescribed me some medication called, oxy something. And then I also ask about bowel symptoms. Are they having constipation or fecal incontinence? Because that helps guide my future plans for treatment. And then as far as a survey, it would be great to do a survey. And actually the most commonly used survey is the OABQ survey. It's most commonly used in research studies. But practically speaking, it's kind of hard to implement it in clinic. So I don't really have many surveys in clinic. And again, the bladder diary would be great, but I often give it to patients and then it never comes back.
Awesome. I think you've kind of like highlighted how something seemingly straightforward is interconnected with so many other issues, like someone's hydration status, their bowel habits, their GYN history, and like conflated with other conditions like interstitial cystitis or even stress incontinence. So it's really important to ask these specific questions that you've outlined and be practical about it. Because it's really hard to complete a diary or these questionnaires in a busy clinic. Can you hone in for us on what specifically you're looking for on a physical exam? What are some things that every general urologist should check for? We know this is part of the guidelines, a thorough physical exam, but what specifically should someone be checking for, documenting?
Yeah, even before I get into the physical exam, and I didn't mention this earlier, but of course, you're getting the history, and then you're asking about the past medical history. And there's certain diagnoses that I want to know about. For example, does the patient have any neurologic history? So am I dealing with neurogenic versus non-neurogenic overactive bladder? Does the patient have narrow angle glaucoma? Because that's going to guide the treatment options that I offer. Another one is impaired gastric emptying. It's not something that maybe someone knows that they have, but it might be on their problem list. And then high blood pressure and whether it's adequately controlled. I want to know about dementia or Alzheimer's or any memory loss issues. And then diabetes, frequently checking the A1C and seeing how well controlled diabetes is. And then even if a patient has had any type of pelvic cancer, had radiation, all of that's going to factor into the symptom severity. And then as far as prior surgeries, whether they've had pelvic surgery, specifically if they've had incontinence surgery, could complicate the picture. And so after I've gotten all of that, then I get into the physical exam. And so just from the vital signs, is the patient's blood pressure normal at that visit? On just my general inspection, are they obese? Am I worried about obstructive sleep apnea, since that can contribute to nocturia? Is this a frail patient walking with a cane or a walker, someone who has mobility issues, that they're going to have worse urinary leakage? Do they have lower extremity edema? That can contribute to nocturia. And then on the pelvic exam, that's where I just start with visual inspection, looking for any atrophy, especially in a postmenopausal woman. If I see a urethral caruncle, I know that they're going to benefit from local estrogen. I'm looking for prolapse beyond the hymen, specifically stage 3 or higher, because the prolapse can cause some degree of obstruction that could contribute to OAB symptoms.
Walk us through exactly what you mean by that statement, just so the listening audience understands your staging. So stage 3 and higher.
Yeah, so really that's going to be beyond 1 centimeter from the hymen. You see a bulge of the walls of the vagina. And especially if you have anterior prolapse beyond 1 centimeter from the hymen, you're more likely to have some obstructive symptoms that could contribute to overactive bladder symptoms. And then you also want to look for any urethral mass or cyst, any suggestion of a diverticulum. And of course, I'm going to do a cough stress test and make sure I don't see stress incontinence.
Awesome. Yeah. I think that was an incredibly detailed explanation. Is there anything else that you would, other than as the guidelines recommend, getting a urine test and a post-void residual, anything more you do after that initial consultation? Say, again, this index patient has clear urge symptoms. The exam is reassuring. There's no prolapse. They're emptying their bladder well. Anything else you would need before talking about the next segment, like therapeutic options?
Yeah, the bare minimum is a history, physical, and UA. And even a PVR is not necessarily a requirement, but I generally do get one on most of my patients, a post-void residual. But other than that, I have enough information to start offering OAB treatment.
Do you generally physically examine every single one of your new OAB patients or patients who come in with urinary symptoms, incontinence, et cetera? Are you doing full physical exams on most of them?
That's an interesting question because when we had the COVID pandemic, we were doing a lot of telemedicine. And it did seem like we were able to manage patients with overactive bladder just with an initial telemedicine visit. It is best practice to do a physical exam at some point at a future visit, especially if initial therapy isn't successful.
And just anecdotally, how often do you think you find something? If you were to examine 100 patients, like our index patients, how often do you think you find something on your physical exam that would, meaningfully add to the diagnosis or potentially change your management?
Well, a lot of postmenopausal women will have some degree of atrophy. And so treating with vaginal estrogen is going to be a nice complement to overactive bladder. But the actual finding prolapse or a urethral diverticulum, that's going to be a different pathway that I follow, is much rarer. There are a lot of patients with just idiopathic overactive bladder, more than 30 million. So I think the vast majority of patients probably won't have something on physical exam.
So let's talk. So you gave a great outline of kind of how you evaluate your patients and how you examine them. Let's talk about treatment recommendations. So, what do you talk to patients as far as lifestyle changes, dietary changes, weight loss, pelvic floor muscle exercises, things like that are non-pharmacologic? How often do you counsel patients about these things, and how successful do you find these different options?
Well, there are some things that patients absolutely need to work on. For example, if they're smoking cessation is key. And I try to use motivational interviewing when I'm talking to patients. So I'll ask the patient, what's made it challenging to quit smoking, to try and just get to the next level. And I'll even offer nicotine replacement, meaning nicotine patches or gum to help patients with smoking cessation. When it comes to diabetes, if their diabetes is poorly controlled, I'll ask them, like, what change could help you better control your sugars? And then they may share something about their diet or their inactivity. And then, weight loss, it's a sensitive topic, but I will explain that weight loss can reduce pressure on the bladder and it can relieve urinary symptoms. So is there anything you think you could work on? And encourage patients to come up with potential solutions themselves. And of course, caffeine reduction is going to be helpful. And even there are some other bladder irritants that maybe patients could cut out of their diet. And our subspecialty, SUFU, the website, has really great handouts that I give to all my patients. 5 changes you can make to improve your bladder, healthy bladder habits, training your bladder. So I give these printouts to all my patients.
I was just going to ask actually about bladder training. This is something that we talk a lot about. How often is this a useful intervention for your patients, and how do you counsel patients to train their bladder so that they're not having to go so often?
So funny, because when you say train your bladder, I think of training your dragon, because I have kids at that age who love how to train your dragon.
How to train your bladder.
You could also train your bladder. Yeah. Some patients are just voiding so often. And so if you've just voided 30 minutes ago, your bladder's most likely empty. And so talk to patients about trying, when that urge comes on, try to contract the pelvic floor muscles, wait for that urgency feeling to go away, and try to prolong the interval. Ideally, patients should be voiding around every 3 to 4 hours. And if you're going every 30 minutes, every hour, you really want to try to train your bladder to prolong that interval.
Yeah. So it's like, what do you say? Oh, this week I want you to wait 5 minutes longer than you normally would urinate. Next week, or, they can set modest goals. I don't know how you frame it to them, or how successful are people without a therapist and doing this on their own in your experience?
Yeah, you're going to be way more successful with a therapist or somebody coaching you through it. But for some people, there's just a lot of logistical issues with going to a physical therapist, so they'll try at home. And I think there's nothing to lose in trying bladder training and pelvic floor exercise. And so every patient should give it a try.
So you talk to your patient about dietary changes and maybe some bladder training, and let's say it's just not effective, and you move on to pharmacologic therapy. Now, there are a host of different oral medications that are useful for patients who have overactive bladder. What is your approach to choosing one of the many medications? How do you make the choice? How do you counsel patients about which medicine may be best for them, side effects, and so forth?
Yeah, so when I'm initiating medical therapy, my first choice is a beta-3 agonist, and it's purely from a side effect profile. Because the side effects for the beta-3 agonist, less than 4% chance of headache, maybe a stuffy nose, UTI. It's quite low rate of side effects, and the actual side effects themselves aren't that severe. On the other hand, with antimuscarinics, some patients will have dry mouth, constipation, and I think the potential impact on memory or the cognitive changes are the most worrisome. And so that's why beta-3 agonists will be my first choice.
Are you talking, especially to your older patients, about the risk of cognitive impairment or cognitive worsening with anticholinergics? And if so, how often is this a major deterrent for the patient, where they're just like, I don't even want to risk that anymore?
Yeah, absolutely. I tell patients that it could potentially affect their memory. And so most patients don't want to take that chance. That being said, one of the antimuscarinics, trospium, because of its molecular structure, it's a quaternary amine. It's less likely to cross the blood-brain barrier. So if I am unable to prescribe a beta-3 agonist, then I will prescribe trospium as an alternative.
And how long do you give it? Let's say you give patients Gemtesa or trospium or whatever. How long do you trial it to know if it's actually going to help them or not?
So the SUFU overactive bladder care pathway recommends 4 to 8 weeks. I think that's kind of long. So I think if a patient's tried it for a shorter interval and they haven't seen efficacy, I'm open to switching therapy.
Nitya, I totally agree with you about the side effects of the anticholinergics, antimuscarinics. The data is pretty compelling that they can have really long-lasting bad cognitive side effects. So I've changed my practice a lot as well, and I favor the beta-3 agonists for first line, and I'm even starting to do some of that for some of the stent colic type symptoms as well for my stone surgery. One thing I found frustrating is the sort of insurance coverage for the beta-3 agonists. How do you approach that, and how do you help patients navigate that?
Yes, it's quite a challenge, and it's really a burden on my office staff who has to go through all the prior authorizations and communication with the insurance companies back and forth. And yeah, I've been told by patients that their prescription will cost $300 a month. And so cost and insurance coverage is certainly a challenge. And so if neither one of the beta-3 agonists is covered, then I will defer to trospium as an alternative.
I think that's an important point, that it's labor intensive administratively to get the patient the preferred medication. And unfortunately, sometimes there's a trial that needs to happen with certain antimuscarinics that can have cognitive side effects. And potentially this could drive people towards more minimally invasive therapy if they're not able to get the oral agent soon enough or without this trial. So speaking of our patient, say she returns stating she's had refractory urgency and urgent continence, even after an adequate trial of, say, a beta-3 agonist with a 4 to 5 pad day requirement. She desires of more therapy because she wants to be completely dry. You do urodynamics and it shows a 300 cc capacity bladder. There's no stress with or without the catheter. But when you're filling her, you see low-level phasic detrusor overactivity with filling. I mean, first of all, let's take a step back and ask, would you have done urodynamics on this patient in the first place, having failed oral and or conservative therapy?
With a patient with a normal post-void residual, no other voiding symptoms, I would have been comfortable moving on to advanced therapies even without urodynamics. But the patients who I would pursue urodynamics in, if it's a mixed picture, they have stress incontinence and urge incontinence, and it's kind of hard to differentiate which is worse, or if they've had any prior pelvic surgery, that there could be a component of obstruction or some other complicating factor. And then cystoscopy, also very rare that I do it. There has to be some other indication, like a recurrent UTIs or microhematuria.
I was just about to ask about the yield of cystoscopy if you've already done the pelvic exam. So thanks for touching on that.
So Nitya, how do you explain the next line of therapies, the third line therapies, the minimally invasive options like Botox, PTNS, sacral neuromodulation to your OAB patients? And how do you put it into context, comparing them, the different efficacies, the potential complications? Seems like a really complicated discussion to get into with these patients from time to time.
Yeah, it can be overwhelming because there are so many options. But I tell patients, if the medications don't work, we can move on, and we have several options. And most people are familiar with Botox. And so I'll say, just like people get Botox for their face, I can give you Botox for your bladder. And it's going to help relax the muscle, help your bladder hold more urine for longer periods of time. It'll last on average 6 to 7 months. And the main side effects or complications are going to be urinary tract infection and potential need to catheterize your bladder to empty it if you're not emptying it all the way. And the actual chance of that happening, in the studies, it's about 6%. And that's roughly what I see in practice. Around 6 to 10% of patients may need to do clean intermittent catheterization because they're not emptying their bladder. But the vast majority of my patients don't experience side effects. And on the other hand, then there's neuromodulation. So I tell patients about stimulating the nerves or calming down the nerves so that your bladder is not so overactive. And there are different ways to approach that. So directly in the back to the sacral nerves or in the ankle. And as far as which treatment is the best, we only have one study that's done a head-to-head comparison of Botox versus sacral neuromodulation, and that's the Rosetta trial. So we do have 2-year data on that. And the reduction in leakage episodes was pretty similar. There was slightly higher satisfaction in the Botox arm, and patients were more likely to advocate or endorse that treatment. But there was also a higher risk of UTI in that group. So I feel like the outcomes are pretty similar for Botox and sacral neuromodulation. And so I just ultimately leave it to patient preference. And so when you tell people about an injection in the bladder, some people are very turned off by that. Or if you talk about a therapy in your back, some people are very turned off by that. So I really let the patient drive based on their preference.
Are there any patient-specific factors that make you gravitate to one option or another?
So any patient that has a post-void residual higher than 100 ml, I am going to counsel that there's a potentially higher risk of needing to do catheterization. So I may be a little more reluctant to pursue Botox in that patient. If someone is high surgical risk, and even to take to the ambulatory surgery care center under sedation, I may be more inclined to pursue Botox in that patient. So there's certain patient factors that would make me lean towards one therapy.
Are you doing most of your Botoxes in the office with a flexible scope or in the operating room with a rigid scope?
Yeah, most of my Botox injections are done in the office. It's only if a patient requests it to be done under sedation. Otherwise, I would say 95% of my Botox injections are done in the office.
And do you do anything special to prepare patients for an intravesical injection? Do you put any intravesical lidocaine in there, or do you use jelly, or do you just pop the scope in and give them a few injections?
And is that gender dependent?
So actually, we are changing the practice in our clinic and evaluating it. So thus far, we had been doing 20 minutes of an intravesical lidocaine instillation, but we're now starting to give people a peridium to take 2 hours before their visit. And And a lot of patients have been tolerating it. And so that just makes the workflow even easier. The visit is so much faster for the patient if they take the pyridium ahead of time.
You mean the pyridium instead of the lidocaine?
Instead, yeah.
Do you give lidocaine jelly?
And everyone gets lidocaine jelly.
Are you using any of the new devices like the eCoin implant, or is there anything else coming in the pipeline that is making you excited?
Yeah, so there are two major implants out in the market right now. So the eCoin is an implant that is above the tibial fascia and has the battery integrated into it. The one that I've personally done is the Revi, which is an implant that's underneath the fascia, and there's an external wearable battery. And I think it's showing a lot of promise. Really high success rates, but the data is still very early. Up to 2 years. And for patients who are nervous about having something in their back, I think it's a much more palatable option to have something in the ankle. And for those who have had success with percutaneous tibial nerve stimulation, those have been the patients who've been most interested in this option, because with percutaneous tibial nerve stimulation, you come in for a 30-minute session once a week for 12 weeks, and then it's once a month. And that's hard to sustain long-term.
Awesome. And then what has been your experience with PTNS in terms of sustainability, and long-term outcomes for that reason?
Well, for the patients who want the lowest risk advanced therapy option, I think PTNS is that option because it's very extremely low risk. But the biggest challenge is coming in once a week for 12 weeks adherence. Yeah.
Yeah. So this new technology could potentially bridge that gap. So that's really exciting. Moving back to sacral nerve stimulation, for those that are having it, how do you counsel those patients about long-term complications and longevity of the device?
So the main, the issues, there are issues immediately post-operatively, and that's infection risk. And once the patients overcome that, then there's potential risk of needing revision down the road or even removal. And so in the randomized trials, it could be as high as 10%. But I think real world, it can be even higher. And that's because a patient falls, or if a patient suddenly loses a lot of weight, then the generator is more palpable and causes pain. And depending on if you've had a rechargeable versus non-rechargeable device, the real world series shows that the removal or revision rate is much higher for rechargeable devices. I think people struggle with recharging their device. And so I think the revision rates, at least 10% chance of needing revision down the road.
I'm not as familiar with the rechargeable device, but what is the barrier to recharging the device? Is it people forget to charge it, or is it like painful to charge?
I think some people may forget, or they just don't want to do the maintenance. I've had patients who maybe sometimes struggled with positioning the recharger directly over the generator. It's kind of the logistics of it that patients decide, they'd rather have the non-rechargeable device, set it and forget it.
And then do you do both stages in the operating room? Or are you doing one stage in clinic and then the second stage in the operating room? What's your own practice?
If the patient can tolerate the initial stage in the office, that's nice, because then first they trial it, and if it works, then great. Then we go to the operating room. If it doesn't work, then we haven't made an unnecessary trip to the operating room. And from an infection standpoint, I think it's nice to do both stages at the same visit so that they don't have these leads that are sitting there for a week and potentially higher risk of infection. So my preference is to do stage 1 in the office and then the full implant if it's successful.
Yeah, makes a lot of sense.
And then how do you talk to them about the risk of future MRIs and prepare for that with the implant in place?
Thankfully, all of our newer devices are MRI compatible. You may need to turn it off or do some certain adjustments, but all the devices, whether they are sacral or tibial nerve devices, are MRI compatible, which is a huge advancement because in the past, I would have to take out people's devices just so they could get an MRI and then put it back in. And so we don't have to do that anymore.
Awesome. Moving on to Botox and potential complications and long-term outcomes with that. In the immediate post-op period after injecting the Botox, what would be your threshold? You had mentioned you'd have a high threshold to offer Botox to someone who had a PVR over 100 from the beginning. But what would be your threshold to offer someone intermittent catheterization? And even backing up from that, what is your follow-up after routine Botox injection in the office? Question 1. Question 2, then what would be your threshold to offer someone CIC?
So after a first injection, I have patients come back between 2 to 4 weeks to check their urinary symptoms and check a post-void residual. And if they're doing great, then they come back in 6 months for their next injection. If they're complaining of incomplete emptying, that's when I would consider clean intermittent catheterization. I don't necessarily have a numerical cutoff. It's really based on the patient and if they're feeling really uncomfortable. That being said, in the trials, 300 mLs was the cutoff for initiating clean intermittent catheterization, or 200 mLs and having symptoms of discomfort like bladder pain.
And do you routinely have your patients come every 6 months for an injection, or do you ever wait to see like when it wears off and just do the injection at that point? Because it seems like they may have variable lengths of durability depending on the patient.
Yeah. So as a habit, we offer patients a 6-month follow-up visit or repeat injection visit. But if patients are doing great, I tell them to cancel that appointment and reschedule it for when their symptoms have recurred. So I have a few patients who maybe come once a year for their Botox injection and others who come routinely every 6 months.
And then in non-neurogenic patients, how often do you find yourself offering greater than 100 units or like escalating the dose over time because patients report maybe it's less effective? How often do you do that?
Often, 100 units works, but in those few patients that it doesn't work, I have gone up to 200 and counseled them about the potential increased risk of retention. But even in that major trial, the Rosetta trial, where they compared Botox and neuromodulation head to head, they actually used 200 units in that study. So I'm willing to try 200 units if the patient is motivated and pursuing Botox more to really exhaust it as an option.
Well, this was a really amazing overview of a very large topic, and we appreciate your experience and your wisdom here. Can you give us like a couple of bullet point takeaways? Like, what are some of the most high yield concepts here in OAB management that a trainee or a general urologist should really take home?
I think it's really important for us to address comorbid conditions like diabetes, for example. If diabetes is not well controlled, you can throw medication at it, you can throw Botox at it, but really the patient has to get their diabetes well controlled. If a patient is smoking, they really have to address their smoking. And so I think we have an opportunity to really help the patient by counseling them on these behavioral changes that could make a huge difference in their entire life. Also, simple things like limiting caffeine and bladder training, it's worth the effort. Also, think it's really important to set expectations. So I tell patients that we're going to start simple, and then we'll move on to more advanced options. And there are a lot of options that we have that we talked about. And so encourage patients not to give up. And so then finally, I think there's really a lot of opportunity to improve quality of life. And there are a lot of people who are suffering with this condition. So it would be wonderful for there to be more people out there being able to offer these advanced therapies.
Absolutely. That's a great wrap up. And those are some super high yield points. I wanted to, first of all, you know who we haven't heard from much is Alex Small. And I'm going to go off script a little bit, but I want Alex Small to chime in here and give some pearls of wisdom here, or ask a question. Alex, what's going on, man?
Thanks, Chris. Thank you. I wish I had pearls of wisdom. I often found OAB to be very confusing, even though it seems seemingly very straightforward. But once you get into the morass of medications and what works, what doesn't work, as a trainee, I always found it a little bit confusing. I've gotten a better handle on it, thankfully, mostly from Dr. Abraham's mentorship as my colleague at Monefiore. But, I think we're lucky in our practice to have a really strong Urogyn FPMRS group, ERPS group, where we can refer patients. So I like to lean on my colleagues, ask them questions, use them for my own practice insights and lean on their words of wisdom. So I'll pass it back to Nitya with that.
I think that what's really great about overactive bladder is that we do have so many treatment options. I mean, I would have never imagined that I'd be operating in the ankle, and here I am now operating in the ankle. And so I think as a area to subspecialize in, I encourage people to choose it as a subspecialty ERPS, or even just managing OAB in general, because I feel like there's such a spectrum of things you can offer. And one day when I'm tired of doing all the complex robotic and vaginal surgeries, I'm just going to be an office OAB expert.
Nitya, we didn't talk about like combination treatments, like two different medications, or a medication and a minimally invasive therapy. Like, how often do you do that, and what guidance would you give to the group on that?
I'm really glad you brought that up, because there's definitely a role for combination therapy. And so patients could take a beta-3 agonist and a lower dose of an antimuscarinic, and that's been shown to work. I even have patients who maybe combine neuromodulation and they continue their medication, or they're receiving Botox injection, but they'll take medication to make that Botox injection last longer, so they're not coming as often. I even have a few patients who have a neuromodulation device and still get Botox. So doing all kinds of combinations.
And we thank you very much for your time and expertise. This has been really enlightening.
Thank you. This has been fun.
Thank you so much. We really appreciate it.
Thank you for joining us on this episode of Behind the Scope Empire Urology Clinical Case Conversations. We hope our discussion enhanced your understanding of the clinical decision-making process of this high-yield topic in urology. Please subscribe to our podcast and check out other episodes on the Empire YouTube channel.